Hi all. Today we are discussing on ABG interpretation. Uh, we all know about ABGs, how we are using it in our daily life. In ICUs, every day we see ABGs, different kind of ABGs. So we are discussing on that. So first is ABG analysis. Blood gas analysis monitors the following physiologic variables. Mainly, we are looking on arterial oxygenation, which is PaO2, and alveolar oxygenation, which is alveolar ventilation, which is PaCO2, and acid-base status, pH, and tissue oxygenation, PVO2. So we know these are the things we mainly look in an ABG. So mixed venous blood obtained from pulmonary artery via pulmonary artery catheter is used to determine tissue oxygenation. So before starting this, I want to tell you this is a very important topic for DHA examination. When I did my DHA examination, I almost had 6 to 7 questions on ABG itself, but it depends on the question paper. My colleague had all the theory questions. I had mostly ABGs and the calculation parts in my exam questions. So ABG is very important topic. So everyone should be thorough with ABG. So we all know the common sites for arterial blood gas drawing is radial, femoral, and dorsalis pedis arteries. And the most common site is radial artery because of its collateral circulation and the easy accessibility. So I hope all you know modified Allen's test. Can someone tell me what is modified Allen's test? Hello? Hello?
Maybe you can name somebody and then ask question, no problem.
Uh, Actually, I can't see who all are here in the class. So, mm,
Yeah, please somebody answer Fasil or Raid. What is Alan's test? That's what she's asking. I think they
okay.
are shy to answer, Sonia. You have
Okay,
to
I'll continue. Okay. So, modified Allen's test is the test which we perform to see if there is collateral circulation. So, what we do is we ask the patient to uh, put his or hands like this, close tight, and then we'll close the radial, put pressure in radial and ulnar arteries, and we'll slowly release the pressures from the ulnar artery. So the hand should become pink in 10 to 15 seconds. So if it is becoming pink in 10 to 15 seconds, that means Allen's test is positive. So if you don't see this, if it is not pinking, then it means it is negative modified Allen's test. So we should perform on the next hand, see if there is collateral circulation in the next hand, and then perform an ABG. Okay, I think everyone is clear on that. Is it clear?
Yes, clear.
Yeah, okay. So next is ABG sampling. I know you all will be knowing how we take ABGs. I think all of us have taken ABGs and are doing it every day in our works. So ABG sampling via an radial artery. Can someone explain the steps? Okay. So what we do is first we'll explain the procedure to the patient and then perform and modify the lens test. Then we'll place the hand, we can keep a towel under the hand patient's wrist to keep the wrist hyper extended. Then we can clean with an isopropyl alcohol swab, and then we should wear a gloves, and if needed we can give a local anesthetic. If not, then we'll take the heparinized syringe and palpate the pulse, and then introduce a needle in 45 degrees angle with the bevel tip pointed up. Okay, and once we puncture the artery, we can see the blood in the hub, and we'll withdraw 1 ml of blood. And it is important to give some pressure in the site for 3 to 5 minutes after taking the ABG. Okay. I think that's all clear. And always we know that we should, before putting the blood in the ABG machine, we should clear all the air bubbles. It can, what do you say? It can manipulate the results. So if there is air bubble, the PaO2 will be shown high, PaCO2 can be shown as less than normal. Okay, and that's how we sample the ABG. And patient's temperature, we should always, uh, after taking an ABG, we should mention these things. What are the name of the patient, MRN or MRD of the patient, then which ventilator settings the patient is on, FiO2, mode of settings, FiO2 rate, PEEP, tidal volume or pressures, everything we should mention in the ABG result. And also patient's temperature, it can affect the value sometimes, but not very significant. Fever shifts the HbO2 curve to the right, indicating that hemoglobin more readily releases O2 to tissues, but does not pick up the O2 as easily. This can affect the PaO2 values in the ABG, but it is not very significant. So arterial PaO2, the PaO2 is a portion of the O2 that is dissolved in the plasma of the blood. For every 1 mm Hg of PaO2, there is 0.003 ml of dissolved O2. So I think this for every 1 mm Hg of PaO2, there is 0.003 ml of dissolved O2. I think it is mentioned in some other chapters also, and there are some calculations regarding that in other chapters. Okay. Then alveolar PaO2. This is the equation for alveolar PaO2, which is Pb minus 47 mmHg, that is PH2O into FiO2 minus PaCO2 into 1.25. So this is mainly important in finding the AA gradient. The normal AA gradient is 4 to 12 mmHg. AA gradient is alveolar PaO2 minus arterial PaO2. So for the exam point of view, for this equation, we can simplify it as PB is always in the equation, it will be given as in the question, it will be written as 747. So PB value is 747. So to simplify the equation, we can 747 minus 47 is 700 into FiO2. FiO2 we always use the equation as if it is 21%, we always use as 0.21. So 700 into 0.21 we can simply use in the equation as 7 into FiO2, that is 21. We can use it like that for the exam point of view. And also for the second part of the equation, PaCO2 into 1.25, you can simplify it as PaCO2 plus 10. So it is easier for the calculations in the examination. So the answers will be almost similar, so that we can save time. And in the HA, they won't give you a paper or pen. There will be a calculator in the system itself. So we can just use that. There is no paper, pen we can use. So always use a simpler methods for calculations. So this is what I said now. This is a question to find AA gradient, that is PA minus AO2. I think, can you all just try to do this question and tell me the answer using the simplified method? Did anyone get the answer? Ma'am, can I continue?
201, somebody has written Nima.
I can't see the chat box also.
Yeah,
Okay.
201. Nima,
Yes,
you can open the mic and talk, okay? Because Sonia can't see it.
Hi ma'am, is it 201?
yes, it is 201. So, so always try to use the simpler method. That is, you can use 7 into FiO2, that is 50. Yeah. 7 into 50 minus PaCO2, there's a typing error. PaCO2 plus 10. So the answer is 201. Okay. I hope everyone got the answer. Okay, I'm moving on. So next is HbO2 dissociation curve. We Hello. Next is HbO2 dissociation curve. So we all have studied this in our physiology first year classes. So I hope all you know HBO dissociation curve. So this curve plots the relationship between PaO2 and SaO2 and the affinity that HB has for O2 at various saturation levels. So this is an S-shaped or sigmoid curve that indicates that PaO2 levels of less than 60 mmHg, there is small increase in PaO2. Small increase in PaO2 results in fairly large increases in SaO2. This is set from this curve, ODC curve. Then the flat portion of the curve, which is a plateau, indicates that at PaO2 levels above 60 mmHg, saturations rises slowly. So there is right and left shift of ODC curve. Shift to right, it means the affinity of HB for O2 has decreased. That means the HB will release O2 to tissues readily. The factors that shift the curve to the right is hypercapnia, acidosis, hyperthermia, increased levels of 2,3-diphosphoglycerate. You should always remember this factors for right shift and left shift. Okay, if you remember one, you can you'll know the other also. So always try to remember this because I had one question on this also. Factors that shift the curve to right is hypercapnia, hyperthermia, increased level of 2,3-diphosphoglycerate, and acidosis. So every values, that is hypercapnia, hyperthermia, increased level of 2,3-diphosphoglycerate. That means everything is increasing in the factors for the right side shift. And acidosis and alkalosis, it is almost like pH will reduce in reduce pH is a factor for right shift. Okay. So the shift to left, it means affinity of HB for O2 has increased, or HB will not release O2 to the tissues as readily. The factors are the opposite to the right shift. It is hypocapnia, hypothermia, decreased level of DPG, alkalosis, and HbCO. So the next is Haldane effect and Bohr effect. Haldane effect are as O2 diffuses from the alveoli to the blood caused by the pressure gradient, it enters a red blood cell where it combines with HB. As O2 combines with HB, the release of CO2 is enhanced. This release of CO2, this effect is called as Haldane effect. And as a RBC travels to the tissue, it releases the O2 because elevated CO2 levels which are present around tissues decreases affinity of HB for O2, and this is called Bohr effect. And the next is hypoxemia. You all know what is hypoxemia and the levels of hypoxemia. Normal PaO2 levels are 80 to 100 mmHg. Mild hypoxemia means 60 to 79 mmHg. Moderate hypoxemia is 40 to 59 mmHg, and severe hypoxemia is less than 40 mmHg. PaO2 values. Then P50, we can also see this P50 values in ABGs, which is the O2 tension at which 50% of HB is saturated when the blood is at 37 degrees Celsius, has a PaCO2 level of 40 mmHg and a pH level of 7.40. The normal P50 is 26.6 mmHg. And the relation between P50 and affinity of HB is inversely proportional. That means as P50 increases, the affinity decreases, and P50 decreases, affinity increases. And SaO2, it refers to the quantity of O2 being carried by the HB compared with the maximum that may be carried. Normal SaO2 level is greater than or equal to 97%. I think this much is clear for everyone. I'll
Yes.
continue. Thank you. CO2 transport and alveolar ventilation. So CO2 is carried in blood in three ways mainly. That is as dissolved in plasma, bound to HB, and as HCO3. So this CO2 is carried as dissolved in plasma and also in the blood. When it enters the blood, it is some part of it is bound to HB, and the most part, what happens is it combines with water molecules and HCO3. HCO3 minus and H plus is formed. So it is also carried as HCO3 minus. So when we always think about ventilation, alveolar ventilation, we always know it is about the PaCO2 levels. So the adequacy of ventilation is determined by the PaCO2 level, and the normal range of PaCO2 is 35 to 45 mmHg. So PaCO2 of less than 35 mmHg is called hypocapnia. We all know that. And it is caused by increased respiratory rate, that is excessive CO2 elimination or hyperventilation. So PaCO2 levels of greater than 45 mmHg indicate hypercapnia, which is inadequate CO2 elimination by reduced respiratory rate or hyperventilation. So PaCO2 levels increases when the minute ventilation, that is respiratory rate into tidal volume decreases or dead space increases. So next is the main topic, acid-base balance. Okay. Normal pH is 7.35 to 7.45. A pH of less than 7.35 is termed acidosis and indicates a higher than normal hydrogen ion concentration. So we all know what is acidosis and alkalosis. Acidosis is caused by either increased PaCO2 or decreased HCO3 levels. And pH of greater than 7.45 is termed as alkalosis. It indicates below normal hydrogen ion concentration, that is alkalosis, occurs as a result of decreased PaCO2 or increased HCO3 levels. So respiratory versus metabolic components. So if the pH change is due to PCO2 change, it is respiratory disturbance. And if it is due to the HCO3 levels, then it is metabolic disorder. We all know that. And an increased PaCO2 will always result in decreased pH, that is respiratory acidosis, and a decreased PCO2 level results in an increased pH, and it is respiratory alkalosis. So PCO2 and pH is inversely proportional. If PCO2 increases, pH decreases. PCO2 increases, then pH decreases. Okay. Okay. So if the acidosis, that is pH level less than 7.35 is caused by increased PCO2 levels, then it is called respiratory acidosis. And when the pH is greater than 7.45, which is caused by PCO2, decreased PCO2 level of less than 35 mmHg, then it is called respiratory alkalosis. So the metabolic results, metabolic is when HCO3 levels change in HCO3 level result in pH changes. So a decrease, HCO3 and pH is inversely proportional always. That means if HCO3 is increasing, pH will increase. If HCO3 decreases, pH decreases. So for a decreased HCO3 level less than 22, then pH increases. pH decreases to 7.35, less than 7.35, it is called metabolic acidosis. And when the HCO3 level increases greater than 26 and the pH increases greater than 7.45, it is metabolic alkalosis. Okay. Then pH compensation. pH compensation means keeping the pH on the our body tries to achieve the pH levels in the normal range by either manipulating the HCO3 or carbon dioxide levels. So bringing the pH level to normal range by this HCO3 and CO2 is called compensation. So if PCO2 initially changes the pH, then HCO3 will change accordingly to bring the pH to normal. So how it is happening means if pH is, if HCO3 increases and as a result pH decreases, that is a primary thing, then the HCO3 will try to, HCO3 will increases trying the pH, trying to keep the pH in the normal range. Okay, there is partial compensation and complete compensation. When we are looking for DHA exams, it is uncompensated, partially compensated, and compensated mainly we are looking. So if the pH is not in the normal range, it means it is either partially compensated or uncompensated. First, we will, in this first question, A, we will see that pH is less than 7.25. That means it is either uncompensated or partially compensated. We know that. So it is an acidosis less than 7.35. So the main cause of this acidosis, we can see that PaCO2 is increased and HCO3 is increased. So what causes the pH to go to the acidosis side? Is it the PaCO2 increased or HCO3 increased?
HCO3?
Always PaCO2 is inversely proportional to pH and HCO3 is directly proportional to pH. So in this case, acidosis is caused by PaCO2 because PaCO2 have increased, that have caused the pH to reduce. That is a primary cause. Okay. When the HCO3 increases, that means the pH will increase. That means it should be, if the metabolic was the primary cause, then pH should be above 7.45. Okay. You got it?
Yeah.
So in this case, the primary is respiratory. That means the PaCO2 is increased, and that's the reason why pH is in acidotic side. So here, then, so we know the primary thing now, it is a respiratory acidosis. So the compensation for respiratory acidosis, as we have already told, if the PaCO2 is the initial cause for acidosis, then HCO3 will change accordingly to bring back the pH to normal. So here, HCO3 is increasing to bring the pH to normal side for the compensation. Okay?
Okay.
Do you understand?
Yeah.
So, and here we can say it is partially compensated. Why? Because pH is not in the normal range still. Okay, so it is a partially compensated respiratory acidosis.
Okay.
Is there any doubt?
No.
Okay. So, in the question B, we can see the PaCO2 is same, 58, but here we can see the HCO3 have increased more, and the pH is in the normal limit, 7.35 to 7.45 to 7.37. So it is compensated respiratory, compensated or chronic respiratory acidosis. Okay.
Okay.
Okay. So, can anyone tell me what is a primary cause in this first question A?
Respiratory.
Yes, respiratory. It is respiratory
Alkalosis.
alkalosis. Yes, the PaCO2 have decreased, which causes the pH to increase to 7.53. So next we look on HCO3. HCO3 is in normal limit or reduced?
Reduced.
Yes, reduced. So it means some compensation is happening, but the pH is still not.
Sonia, 1
Yes.
second. I think all of you must write down these ABGs in your book so that you can practice it later, okay? Yeah, that's all, Sonia.
Yeah, okay. So here the HCO3 have reduced from normal range in order to bring back the pH to normal, but still the pH is on the alkalotic side, greater than 7.45. So it is a partially compensated respiratory alkalosis. Similarly, in the next question, we can see it is the same respiratory alkalosis, but the HCO3 have come some more down, decreased some more, so that the pH is in the normal range. It is 7.43. So it is between 7.35 to 7.45. So it is fully compensated respiratory alkalosis. Okay. You understood? Everyone understood?
Yes.
So the next we are looking upon the metabolic thing. So in the first ABG, can anyone tell me what is the primary cause?
Metabolic.
Yes, it is metabolic acidosis. So in order to bring the pH to normal range, the PaCO2 have reduced. What happens when the PaCO2 reduce? What happens to the pH?
pH also will reduce.
When PaCO2 decreases, what happens to the pH?
pH will increase actually.
Yes.
The normal
Yes.
range.
Yes. When PaCO2 decreases, pH will increase. So the compensation here is PaCO2 is decreasing so that the pH will increase from 7.21. Okay. So here the primary is metabolic acidosis, and we can see the PaCO2 is not in normal range, it is reduced. So that there is some compensation happening, but it is not, pH is not in normal range still. So it is a partially compensated metabolic acidosis. Okay. So the next thing in the next question we can see it is also metabolic acidosis, but the PaCO2 have reduced some more and the pH is in the normal range, which is 7.36. So it is a fully compensated metabolic acidosis. Okay. So, can someone explain what is happening in the first question?
Metabolic alkalosis.
Yes, it is metabolic alkalosis. And what is happening for the PaCO2?
PaCO2 also increased.
So what happens to the pH when PaCO2 increases?
It will bring to normal.
Yes, pH will increase so that the pH will come to a normal range. So it is a partially compensated metabolic alkalosis. In the next, we can see PaCO2 is some more increased and the pH is in the normal range. So it is a fully compensated metabolic alkalosis. So I think everyone understood what is respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis, and the compensations. Okay. So when a compensated blood gas measurement is interpreted, if the compensated pH is 7.35 to 7.40, that means it is more to the acidotic side. So we can decide whether the PaCO2 or HCO3 has caused the initial acidemia. Okay. Similarly, if the compensated pH is in the range between 7.40 to 7.45, then initially the pH will be in the alkalotic side. So we can decide whether the PaCO2 or HCO3 have caused the initial alkalosis. And as we all know, metabolic compensation takes several hours to occur, whereas a respiratory compensation may occur in minutes. So, the next is mixed respiratory and metabolic component. So, mixed ABGs we have seen, it is caused when PaCO2 and HCO3 both causes a change in pH. Both causes a pH to move in the same direction. Okay, that is called mixed or combined respiratory combined component. Okay, so in this question we can see the pH is 7.21. That means it is in acidotic side. So what all causes the pH to move to acidotic side?
PCO2 increased and HCO3 decreased.
Yes. When PaCO2 increases, it can cause pH to decrease, and HCO3 increases, the pH can decrease. In this question, we can see PaCO2 have increased, which have caused pH to decrease, and also HCO3 have also decreased, that have caused pH to decrease. So this is a mixed ABG, mixed respiratory and metabolic disorder. Okay. Mixed respiratory and metabolic acidosis. All are clear on that?
Clear, ma'am.
So these are the normal values. We all know pH 7.35 to 7.45, PaCO2 35 to 45 mmHg, PaO2 80 to 100 mmHg, and HCO3 22 to 26 milliequivalents per liter. Base excess +2 to -2 to +2. There is a typing error. So these are the basic steps to interpret an ABG. Determine whether it is acidotic or alkalotic. This is what we have been doing in the previous slides. Okay. Determine whether pH is a result of change in PaCO2 or HCO3. When this is determined, observe for signs of compensation and then determine the oxygenation status. Look for PaO2, mild, moderate, severe. So we'll do some ABG examples. This is the first question. Can someone do this?
Respiratory acidosis.
Yes. And the compensation?
Not upward.
No compensation.
No compensation. And the hypoxemia?
Acceptable range 80 to 100 range 81.
So it is normal. So these are the things which we now look for interpreting the ABGs. So acid-base status, it is acidosis. Ventilatory status, it means elevated PaCO2, that is the patient is hyperventilating, which is causing the decreased pH. Metabolic status is normal, so no compensation is happening. Oxygenation status is normal PaO2. Interpretation, so it is uncompensated or acute respiratory acidosis. So what we do to correct respiratory acidosis? We can either increase patient's minute ventilation by increasing respiratory rate or tidal volume if the patient is already on mechanical ventilation. Okay. So this is the next question.
Respiratory alkalosis.
Yes. And the compensation?
Not compensated. Oxygenation status.
Okay. So it is acid-base status is alkalosis, decreased PaCO2, that means patient is hyperventilating, normal HCO3 levels and normal PaO2. So it is uncompensated respiratory alkalosis. We can either reduce rate or tidal volume if the patient is on mechanical ventilation. Next question.
Respiratory alkalosis with hypoxemia.
Normal ABG with hypoxemia.
This is a normal ABG. Okay. So we can
Borderline actually, right? When we say 7.35 to 45, we actually take 7.4. So more than 7.
So the thing is, when we look in our ICUs and all, we see it like 7.4 for PaCO2 mid-range 40 and HCO3 mid-range 24. But in this exam, we'll look for the range only. If it is 7.35 to 7.45, in between it is normal. Okay.
Yeah. Okay.
So that is a difference when we are doing DHA and in our normal setting. Okay, so the PaCO2 is also in the normal range. HCO3 is also in normal range, and PaO2 we can see here, it is moderate hypoxemia. What is the range for moderate hypoxemia? Hmm?
50 to 60.
I can't hear.
59 to 40.
Yes. Okay, so it is moderate hypoxemia. Okay, so we can give oxygen for the patient. Okay, so next question.
Fully compensated respiratory acidosis.
So acid base, we can see it is on normal range. That means it is compensated, and the PaCO2 have increased. So it is initially a ventilation issue, that is PaCO2 issue, and metabolic status, that is HCO3. It is also increased in order for the compensation, and oxygenation status is moderate hypoxemia. So it is a compensated respiratory acidosis with moderate hypoxemia. Okay. Next question.
Mixed disorder.
So here pH is in the acidotic side. PaCO2 43, is it in normal range?
So metabolic acidosis.
Metabolic acidosis. Any compensation?
No compensation.
No compensation. Uncompensated metabolic acidosis. Oxygenation status is normal. No hypoxemia. Next question.
Metabolic acidosis.
Compensation.
Partially compensated.
Okay. It is partially compensated metabolic acidosis with normal oxygenation. Okay. Then blood gas analysis or POC analysis. POC analyzers are portable blood gas analyzers that allow blood gas testing to be done at or near the patient bedside. POC testing is accurate and result in quicker response time for the analysis than when the blood draw is from the patient and then transported to the laboratory. So it is POC analyzers, we all know it is like we are testing the blood gas in the bedside, patient bedside. I think some of the ICUs will be having POC analyzers. POC analyzers are often handheld devices and usually require only a few drops of blood for analysis. The blood is placed in a disposable cartridge. Separate cartridges are used depending on the test to be done. Blood gas levels as well as HB, hematocrit, electrolytes, glucose, blood urea, nitrogen, and creatinine may be analyzed. The sensors on the POC analyzer is automatically calibrated. The POC analyzer calculates, displays, and stores the result. The result can be placed into hospital information system or central laboratory for storage and reporting. And the quality control procedures. Blood gas analyzers should undergo 1 and 2 point calibrations on a routine basis. We all may have seen in the ABG machines that before testing all the samples, each each samples, we do a 1-point calibration. Most of the ABG machines now have it automatic, have this automatic calibration programmed. So 1-point calibration is always performed before testing on each ABGs, and the 2-point calibration is usually performed every 8 hours. Then 2 different buffers are used to perform a 2-point calibration on the pH. The PCO2 electrode is calibrated with the use of 2 gas concentrations, and the PO2 electrode uses a gas mixture of 0% O2 and another with 12% or 20% O2 for the 2-point calibration. Then the criteria for acceptable results are below. pH must be within 0.04 of the target value, and PaCO2 must be within 3 mmHg of the target value, and PO2 must be within 3 mmHg of standard deviation. Then internal statistical quality controls applies statistical and rule-based procedure to help identify and correct instrument error. The result of the control media analysis are plotted on the graph and compared with the statistically derived limits, typically to standard deviation ranges. Analytical error is indicated when the control results falls outside these limits. These topics are, I think, not very important for the exams, but we should know about this. And there are 2 types of errors, which is random error and systemic error. Random error is an isolated result outside of the control limit. A single result outside the control limit, it is called random error. And systemic error, also referred to as bias or trending, and indicated by a recurrent shift in data points outside the statistical limit. It is a recurrent error. Okay. So external quality control is the system by which laboratories can compare the accuracy of their result with the result obtained from other laboratories. 2 laboratories can compare with their results, and that is called that is what mean by external quality control. Testing is typically done 3 times per year using 5 sample tests. Acceptable performance is indicated by a specified range around a target value, for example 0.04 for pH. So similarly, this external quality control is done for this blood sugar testing devices also. It is the same, the external quality control. So I'll give you some questions. You can all answer it. I prefer you not using a pen or paper while doing this, because in the exam you won't be provided with a pen or paper. Okay. So first you can see the first question and give me the answer for the first question. Sama.
Metabolic
Metabolic
acidosis
acidosis.
And compensation.
not compensated.
And compensated. And about the oxygenation.
Normal limits.
Yes. The next question. One of you can answer, and please explain also, so that others can also understand.
Fully compensated respiratory acidosis, because pH is 7.35 to 40 range, so that is acidotic part, and PCO2 is increased, so that and HCO3
So
also
respiratory acidosis. Okay. So since the pH is in normal range, it is compensated respiratory acidosis. And what about the oxygenation?
hypoxia is present. Hypoxemia.
Moderate, mild, or severe?
Moderate.
Okay. Now next question. Someone else can answer the next question.
Respiratory alkalosis.
Hmm. Can you explain?
Yeah, the pH is in higher side alkalotic side and bicarb is in alkalotic range and sorry, PCO2 is in alkalotic range and bicarb is not compensating. So it is uncommon
PaCO2 is in alkalotic range means PaCO2 have decreased.
decrease.
Yes. And the bicarb?
It is in the normal range, so it is uncompensated respiratory alkalosis with no
Oxygen.
hypoxemia.
Okay. Next question.
The combined disorder because
Yes.
pH is 7 in acidotic range,
Hmm.
PCO decreased and HCO3 decreased. So HCO3 decreased means that is like metabolic, but PCO2 also increased. So it's a mixed disorder, respiratory plus metabolic. And
Yes.
hypoxia is also present, mild hypoxia.
Mild hypoxemia. Yes. Next question.
Fully compensated respiratory alkalosis
Yes. Oxygenation status.
is in normal range.
All of you got the answers for that also?
Because pH is more than 7.4,
Hmm.
so that is towards alkalotic range,
Hmm.
and PCO2 decreased. So most likely respiratory alkalosis, and it got compensated. So HCO3 decreased.
Hmm. Okay. Next question. Last question.
Partially compensated respiratory acidosis with normal
Oxygenation.
uh,
Yes. It is also correct. So I think you all are thorough with this. This is a question on to find A gradient. So you can do this also. And please try to do it on your calculator and not use a pen and paper. Once you get the answer, please tell me also. You can use a simplified version of the equation. Anybody got the answer? Anybody got the answer?
140.
140? Can you also explain how you did the question?
Is it 165?
Not 165, I think. Not
Ma'am, is it
165.
145?
Yes, it is 145. So how you got the answer?
And 7 into FiO2 40
Yes.
minus PCO2 45 plus 10
Okay. So we'll get
minus P.
alveolar oxygenation and then
Okay,
we'll
okay.
we'll minus the PaO2, arterial oxygen. Okay. All are clear about that? I'm moving on to the next question. Which of the following ABG measurements determines how well a patient's lungs are being ventilated?
PaCO2.
PaCO2.
Yes, PaCO2. Then, which of the following blood gas measurements determines the level of tissue oxygenation?
PVO2.
Option
Yes,
D.
tissue oxygenation, it is PVO2. Okay. Then, which of the following condition shifts the HbO2 dissociation curve to the right? ODC curve to the right.
Hypercapnia.
Yes, hypercapnia. And also, can you list the other factors for right shift?
Acidosis.
Yes,
Hyperthermia.
yes. And increase in 2,3 dpg. Okay. So the next question. A patient with 2 liter per minute nasal cannula has the following ABG results. pH is 7.51, PaCO2 27 mmHg, PaO2 62 mmHg, HCO3 23 milliequivalents per liter. So you should interpret this ABG. Can anyone do and answer it?
Acute respiratory alkalosis.
Yes. It is option D, acute respiratory alkalosis, because PaCO2, pH is an alkalotic site, so it is alkalosis, and PaCO2 have decreased so that the pH is on the alkalotic side. So primary is respiratory alkalosis, and HCO3 is in the normal range, so there is no compensation happening. So it is acute respiratory alkalosis. Next question. The respiratory therapist has received an order to obtain an ABG sample from a patient, but an Allen's test indicates collateral circulation not present in the right wrist. At this time, the respiratory therapist would see the options and tell me the answer.
Check collateral circulation in the left wrist.
Yes. Once you see there is no collateral circulation in one hand, check in the other hand. Okay. It is correct. Option D is the correct one. Check collateral circulation in the left wrist. So, next ABG, you can interpret this also.
Uncompensated metabolic alkalosis.
Yes, it is uncompensated metabolic alkalosis. pH is in the alkalotic side, and PaCO2 is in the normal range, and HCO3 is increased. So that HCO3 caused pH to increase, that is metabolic alkalosis. And since PaCO2 is in normal range, it is uncompensated metabolic alkalosis. This one.
fully compensated metabolic alkalosis. Fully compensated respiratory alkalosis with mild hypoxia.
Yes, it is correct. Just fully compensated respiratory alkalosis with mild hypoxemia. So, the following blood gases are obtained on a severe cyanotic COPD patient on a 2 liter per minute nasal cannula. So, the pH is 7.51, PaCO2 29, PaO2 155, HCO3 is 35. Which of the following most likely accounts for these ABG values? Option A is the patient nasal cannula flow was higher than 2 liter per minute at the time of the arterial stick. There is air in the blood sample. The blood was inadvertently obtained from a vein. These represent normal blood gases for severe COPD patients. Which do you think is the correct option? What happened in this ABG? Yes?
Air bubble in the blood sample.
Yes, there is air. So here we can see the PaO2 is increased. So it can also be the first option. Yes. So why did you tell it is air bubble? Anyone? Here in this ABG, we can also see PaCO2 is decreased. In a typical COPD patient, we don't see the PaCO2 decreased. So, since the PaO2 and PaCO2 is affected, both are affected, so it is the air bubble. Okay? It is not just the increased flow. So, the most appropriate answer is there is air in the blood sample. Okay? Clear?
Okay, ma'am.
So, next question. A patient on a mechanical ventilator has the following ABG: pH 7.27, PaCO2 28, PaO2 88, and HCO3 27. What should we do for this patient? Anybody answer? This is the last question.
Increase the tidal volume.
Why did you say increase the tidal volume?
So more washout will happen. Then
PaCO2 is already 28.
Decrease the FiO2
Decrease FiO2, why?
because the patient is already on alkalotic side. If we are looking at that, so the increase in the tidal volume is not valid, and decrease in the ventilator rate is also not appropriate, I think. So by looking at the PaO2, the normal range is 80 to 100 as mentioned. So it will be able, I think it is to decrease the FiO2.
So what about the third option in this?
Lab error means there is not for increase in the PaO2 level. I think
Can
because
you
there is
interpret
no,
this ABG?
I think it is a respiratory alkalosis.
it is
Metabolic
Yes,
acidosis.
it is not alkalosis.
respiratory acidosis.
Metabolic
Uh,
acidosis.
So I
If
think if you are increasing the tidal
acidosis.
volume,
I mean,
first interpret the ABG. Is it a respiratory alkalosis, respiratory acidosis? What
Metabolic
is
acidosis.
If metabolic acidosis is there, HCO3 should decrease less than 22. Here it is 27. So here you can see this is not a correct ABG because if HCO3 is increasing, pH should increase. And if PaCO, that's not happening here. And if PaCO2 is decreasing, that means the pH should increase. So the pH here is less than 7.27. This is not happening. If pH is 7.27, that means the PaCO2 should increase more than 45, or the HCO3 should decrease less than 22. That's not, both of that is not happening here. So it is a lab error. Okay? You can't interpret this ABG.
Okay.
You got it?
Okay. Got it.
So always don't skip an option because that might be the answer. Okay?
Okay, ma'am.
So that's it. Thank you all. If you have any questions, you can ask me. No.
Thank you, ma'am. I'm sorry to ask you. I was little late. This simple way to calculate this PaO2, one question was there. No? I missed
Yeah.
that point.
It is the PaO2 is actually the what we calculate is the original formula is Pb into PH2O, that is 47
Okay.
minus sorry Pb into 47 Pb minus 47 into FiO2, the whole thing, minus PaCO2 into 1.25. That is a real equation. So what we can do is, Pb is always given in the question as 747.
Okay.
So 747 minus 47 is 700. Okay? And the FiO2, if it is 21%, we take it as 0.21. Okay?
Okay. Okay.
So that step we can simplify as 7 into 21. So the FiO2, if it is given as 40, you can do as 7 into 40. Okay?
Okay.
Okay. And the second part of the equation is PaCO2 into 1.25. So
Okay.
simply you can do it as PaCO2 plus 10. That is more easier. Okay? It is only for the exam point of view, and also it won't give you the accurate value, but it will give value nearest to it. Okay, just 1 or 2 difference will be there. Okay.
Okay. Thank you, ma'am.
So what you can use, uses 7 into FiO2 minus PaCO2 plus 10. Okay.
Okay. Thank you, ma'am.
Okay.
7
Any
into
other
F
questions?
plus 7 into F. 7 into FiO2 minus PCO2 plus
Minus, yes, PCO2 plus 10.
plus 10. Thank you, ma'am.
That is alveolar oxygenation, P capital AO2. Then
Okay.
if you want to find the A gradient, you should minus the
Yes.
arterial oxygen from it. Okay.
Okay. Okay.
Any other questions? All of you understood this topic? This is a very important topic for DHA. I got a minimum of at least six questions from ABG. Mainly from the ABG interpretation part. Okay. Okay. I think everyone is clear.
Yes, ma'am.
Soumya ma'am, are you there?
My ma'am is a little busy, so she has asked me to attend. So I guess
Okay.
everyone has asked the questions. Thank you for the class. Thank you so much.
Thank you.